Good evening, everyone. Thank you, ISCCM, for giving me this opportunity. The topic given to me was vascular ultrasound. We are going to summarize and simplify the fundamental sonographic aspects and also discuss some training related issues regarding this topic. So, venous and arterial cannulations are common and necessary practices in critically ill patients worldwide. Although vascular access are usually obtained using the anatomical landmark technique, this practice is not exempt from failure and complications. In this respect, ultrasound guided vascular cannulation has been shown to improve first pass success rate, reduce the number of attempts, improve patient satisfaction, and reduce overall procedure related complications. Therefore, this method is increasingly used as the first choice to obtain a secure vascular access in critical care patients. So I'm going to discuss regarding how to sonographically identify the vessels and all the sonographic anatomy and the problems that will be faced and the training related issues to the vascular ultrasound. So ultrasound guidance has demonstrated an 86% reduction in the rate of catheterization failures, 80% reduction in the arterial punctures, 78% reduction in the number of hematomas, 90% reduction in the number of pneumothorax cases, and a 94% reduction in the rate of hematomas. Thus, the risk-benefit ratio and the cost-benefit ratio clearly point toward a strong recommendation to use this technique. To start with, what is the technique and ultrasonographic vascular anatomy? So this is the linear array transducer that is used for vascular cannulation. The frequency is 7 to 10 megahertz. As we can see here, the black arrow indicates the pointer towards the left that matches towards left of the screen on the ultrasound machine. And this gray straight line also comes towards left side of the machine. So this pointer is very important. We must know how to identify which side of the machine, which side of the screen we are facing, which side of the screen we are seeing. That is why the pointer on the transducer is very important for sonoanatomy. In ultrasound vascular cannulation, there can be both two-dimensional imaging as well as three-dimensional imaging also. But most commonly used is two-dimensional imaging only that comes with a short axis view and a long axis view. So short axis view means the pointer on the transducer is towards the left side. This is the left side of the transducer that matches with the left side of the screen. In the short axis view, the vessels are seen round like for arteries and oval for veins. Like we will see them round or oval in the short axis view. To make it into long axis view, we have to turn the transducer 90-degree clockwise so that the pointer is farthest from the operator, and in this view, we can see the vessels as tubular. This is very important to understand which view you are seeing and how you are cannulating, because the technique of cannulation differs with each view. The other terms which are important are depth, gain, and focus. Adequate depth should be there. Means like all the posterior structures behind the vessel wall should be visible. Adequate depth, like a minimum of 3 to 4 centimeters should be there to avoid damage to surrounding structures. And focus, always the vessel we are going to cannulate, that should be focused in the center of the screen, like this. Between these two arrow marks, the focus should be present. If the focus is not appropriate, or the depth is not appropriate, or the gain is not appropriate, then it leads to difficulty in cannulation and leads to complications such as puncture of the artery, hematomas, posterior wall punctures. The number of complications will increase if we don't concentrate upon the depth, gain, and focus. So how do you differentiate between vein and artery in the ultrasound imaging? So both have the anechoic content. Vein is oval and artery is round. Vein have thin walls and artery have thick walls. Vein is compressible, artery is poorly compressible, and vein is not pulsatile, artery is pulsatile. And on the Doppler, we can see phasic flow on the Doppler, whereas in the artery, we can see the pulsatile flow. So this is an example of the image showing all the artery, vein, and in the short and long axis view. So we are going one by one in the image number A. This is the short axis view. V is the vein and A is the artery. So vein always accompanies the artery and a nerve in the neurovascular bundle. So this is the short axis view where you can see either round or oval shape of the vessels. When we turn the probe into the long axis view, the vessels appear tubular. So this is the long axis view. The vein is appearing tubular here, and in the image C, the artery is appearing tubular here. So coming to the Doppler flows, here in the image D, you can see the vein here, and corresponding Doppler is showing only the phasic flows. Whereas in the image E, artery Doppler is showing pulsatile flow. This is the major difference between the vein and the artery, and you can avoid inadvertent arterial punctures when you want to go for a central venous axis by looking at the Doppler flows. So this image F identifies the superficial vein and deep vein. So superficial vein lies above the deep fascia and the deep vein below the deep fascia. Always the deeper veins are accompanied by arteries, whereas superficial veins are not accompanied by any arteries. Next, ultrasound mapping before cannulation. So always first step is recognize the vascular structure, and the selected vessel should be permeable, superficial, have a secure pathway regarding travel of the needle to avoid damage to the surrounding structures. And when you want to cannulate the vein, patency of the vein must be demonstrated. Vein valves should be avoided because damage to the vein walls can lead to future thrombogenic formation. And veins must have the normal diameter. Central vein, if you want to cannulate, the minimum anteroposterior diameter should be more than 7 mm. And peripheral vein, if you want to cannulate, the minimum anteroposterior diameter should be more than 4 mm. And the optimal distance from skin to the vessel is less than 16 mm to avoid premature dislodgement of the catheter. So when coming to the artery, for artery also permeability should be assessed and there should be no erythematous plaque. We'll see the images for the same. So ultrasound mapping before cannulation. In this image A, we can see vein and artery are accompanied together in the neurovascular bundle. So if you are putting pressure between the arrows, you can see that vein is completely compressible. So that vein is patent. Whereas here in the image B, you can see even after applying pressure, you cannot compress the vein, showing that the vein is having a thrombus inside it. So thrombus formation within the vein and you cannot cannulate the vein. And in the image C, between the arrows, I think everyone can see the presence of the vein valves. These are the valves within the vein that can also be seen during the cannulation. And image D shows the optimal anteroposterior diameter of the central vein. Optimal anteroposterior diameter of the central vein is more than 7 mm and optimal anteroposterior diameter of the peripheral vein should be more than 4 mm. Image E, you can see the optimal distance from skin to the vessel, that is 16 mm. And here in the image F, this is the artery, and this is the presence of the erythematous plaque within the artery. So whenever any thrombus is present, erythematous plaque is present, we have to avoid the cannulation of such veins or arteries because that leads to thromboembolization. So what is the optimal selection for a target vessel? It should be as superficial as possible. They should have guaranteeing a safe pathway away from the key structures. so that avoiding damage to the surrounding structures reduces the incidence of complications. And patent vessel should be present and ruled out a thrombosed vein or an artery. Absence of atheromatous plaques in the selected site for the artery, and absence of valves in the selected site for the veins. And central vein anteroposterior diameter will be more than 7 mm, and peripheral veins anteroposterior diameter more than 4 mm. Skin to vessel distance are equal to 16 mm. So coming to the procedure itself, we have two techniques, static technique and the real-time technique. Static technique is ultrasound guided vascular location marking is done. And once the marking is done, then you will proceed with the technique blindly only. Whereas in the real-time technique, you will have some direct or indirect evidence of the needle entering the vessel. That means you will be clearly seeing how the needle is entering the vessel, whether the guide wire or the catheter is there in the vessel or not. So compared to the static and the real-time technique will need more skill, because you need to coordinate with the transducer, with the needle insertion, and as well as visualization at the ultrasound machine simultaneously. Whereas a static technique, that much skill is not needed. Comparatively, the most commonly used is real-time technique only, and it gives a better performance also. In the static technique, there is no need to use any sterile cover to the probe. No sterile precautions are required, because simply you will mark the presence of the vessel and then proceed with the technique blindly. So that is the difference between the static and the real-time technique. So here I want to show a video regarding the static technique. They are seeing the vessel with the transducer or the probe. They are putting markings till the extent of the vessel. They will connect the markings. Then they will cannulate it blindly. They will not use the probe again. So this is the static technique. So this is the real-time technique, where you are observing the entrance of the needle directly into the vessel using the probe. The entry of the needle into the vessel is directly seen. So this is the real-time technique, which requires more skill, needing coordination of the screen, coordination of the needle poke, needle puncture, and the probe manipulation. Those three are required at the same time. The learning curve is more for the real-time technique compared to the static technique. In the real-time technique, with the needle insertion in relation to the probe and ultrasound bundle, we have two techniques here, in plane and out of plane. So in plane and out of plane are the two most important techniques, where you can understand how the needle is entering the vessel. Okay, first, out of plane is seen in the short axis commonly. Here we can see the transducer is placed horizontally and the needle is placed in the center of the transducer. So the tip of the needle crosses the body of the transducer. So the tip of the needle is never seen. Only a part of the body is seen in the out of plane technique. In plane technique, seen in the long and the oblique axis views, where the transducer is kept vertically and the needle is punctured in the center of the transducer. So the needle traveling along the path of the transducer can be seen clearly. Needle follows the path of the transducer and ultrasound beam. That is why needle is completely visualized in toto. Like from tip to the entire body, how the needle is entering the vessel, it can be seen. So technique-wise, which is better? That also we'll discuss later. So short axis is the out of plane technique. Oval vessel shape, it is oval for the vein and round for the artery. Long axis technique, the vessel is tubular, and the oblique technique, intermediate between short and long axis. The needle tip is usually not observed in the short axis view. The needle body is in fact shown as an echogenic spot. Movement in the soft superficial tissues, as well as flattening of the anterior vessel wall. So in the long axis technique, the needle is completely observed as is advanced through the vessel. And in the oblique technique, it is almost the same as the long axis technique. Advantages of the short axis technique is that you can see the surrounding structures very clearly. So because the vessel is seen as only a round or an oval structure, the surrounding structures are seen very clearly. Here, long axis technique, there is good delineation of the needle and its depth entering the vessel, but the surrounding structures are not seen clearly. So disadvantages is for the short axis, the needle tip is not seen clearly, so that can result in the posterior wall punctures and that pneumothorax in case of subclavian vein cannulations. Whereas in the long axis technique, because of beside structures are not seen properly, there can be damage to the surrounding structures. So when to select the short axis, when to select the long axis. Short axis is selected when the large vessels are present, when the key structures are closer to the target vessel, and thus a tight control of the needle location is required. Long axis is selected when there are smaller vessels, when key beside structures are far away from the view, so that there is no risk of puncturing the surrounding structures. So learning curve for the short axis is shorter. We can learn it very fastly. Long axis view, long axis technique, the learning curve is longer. Overall procedure success is lower for short axis and better for the long axis. Improving needle visit. Next, how to improve the needle visualization. Needle visualization is sometimes cumbersome. Practitioners must be aware of several useful ways to readily improve the needle visualization. So now I'm going to discuss what are the tips to improve the needle visualization. Without the needle seen clearly where it is going and how it is entering into the tissues and the vessel, you cannot cannulate properly, and that increases the risk of the complications. So how to improve the needle visualization? First, proper adjustment of depth, gain and focus should be present. And visually inspect the needle and transducer position and exclude the gross small alignment. So transducer should be moved in a slow, controlled manner using sliding, tilting and rotating maneuvers until the needle shaft and tip have been brought back into the view. So check for a correct alignment between the probe and the needle. Preferably move the probe instead of the needle when the latter is not seen. And avoid moving the transducer and the needle at the same time. And needle bevel should be facing up or down, but not medial position. There are some techniques that will help us to improve the visualization of the needle during cannulation. Those are, one is Skylift technique, the other is heel toe technique, wire and needle technique, and walk down technique. So Skylift technique is best for best recognizing the needle in superficial tissues, mostly for the in-plane techniques. I'll show you each and every technique with videos. So this is a Skylift technique. So Skylift technique, in-plane, used in the in-plane procedure or the long axis view. So we have to elevate the transducer, put the needle under the transducer and allow the transducer to completely lean upon the needle so that needle is always insonated and best recognized. Again, needle is lifted, transducer is lifted, needle is inserted, transducer is allowed to lie upon the needle. That improves the recognition of the needle. This is the Skylift technique used in the in-plane procedures. Needle beam angle. This is very important. The optimal angulation between the needle. This is the needle. This one is the needle. Echogenic structure. This is the needle, and the angle between the needle and the ultrasound beam should be always close to 90. Best is close to 90. Optimal, it should be more than 55 degrees for better visualization of the needle. So sloped insertions are when angulation is less than 55 degrees. So here in the image A, you can see very good angle between the ultrasound beam here, a solid yellow line, and the dotted white line here. That is the needle visualization. This angle is close to 90. That is why the needle is seen very clearly here. Here in the image B, as you can see, there is locked insertion of the needle, and the angle between the needle insertion and the ultrasound beam is less than almost 55. So you can't see the needle here. So what you can do when the needle beam angle is less than 55, or when very sloped insertion is, then we use the heel toe technique. Heel toe technique. So heel toe technique, you can see here. This is the image C is the heel toe technique. Needle we are having sloped insertion, and the transducer is also inclined in some other angle such that the optimal angle is not achieved. So at that time, what you do, instead of changing the needle direction, you can change the transducer inclination in such a way that needle and the ultrasound beam angle optimizes to 90, is closer to 90 degrees, and the needle is seen clearly. This is called as the heel toe technique. Heel toe technique. So Skylift technique, heel toe technique. So next is WIN technique. WIN is a wire in needle technique. So when we introduce some wire within the needle, that increases the echogenicity and the needle is visualized very clearly. So wire in needle, it enhances the echogenicity. I'll show you the video. When you're putting wire inside the needle, the guide wire is inserted, guide wire is removed, and then it is inserted through the transducer, help of a transducer probe. Then you can clearly see the entry of the needle into the vessel. So the advantage of this WIN technique is it's a one for all procedure. So only once when you puncture the vessel, you see that you're inside, you can directly thread the guide wire into the vessel and directly thread the catheter over the guide wire. So that simplifies the procedure for the operator. So this is a one for all procedure. That is the WIN technique. So this is the needle beam. What are the other methods that are used to increase the needle visualization? Echogenic needle designs. So echogenic needle designs are used, but there is, as per the studies, there is no improvement in the success rate, and there is no improvement in the number of the attempts. Only it enhances the needle tip visualization. And the other methods are needle enhancing software and three-dimensional ultrasound. A point to note, color Doppler is not useful in needle recognition. So the other last one is walk down technique. It is seen in the out of plane technique. I don't have an image or a video for the same. Walk down technique, we have to fan the transducer proximally as the needle is advanced. That is walking down the needle. That helps in visualization of the needle. That is the walk down technique. So Skylift technique, needle beam angle, WIN technique, walk down technique. So those are the 4 techniques that are used to enhance the needle tip visualization. So next, you have entered the vessel. You have inserted the guide wire catheter. So how do you confirm the proper vessel cannulation? So visualize the guide wire that is inserted into the vessel. That is the first point that we need to know for proper vessel cannulation. In this video, you can see the entrance of the guide wire into the vessel. That indicates that properly the vessel has been cannulated. And agitated saline flush technique. You can visualize the catheter also. You can see it here. So agitated saline flush technique, you will give 10 ml of saline through the catheter. For a peripheral vein, you can display the micro bubbles running into the vessel. Whereas for central vein, you have to do simultaneous echo in subcostal or the apical view, where you can display the micro bubbles in the right atrium. This is the agitated saline flush technique. I'll show you the video for the same. This is the catheter that is seen here in the vessel. So this is the needle. Needle in the sense like when you're injecting saline, you have to inject needle. And your saline is given, agitated saline, 10 ml. You can see the movement of the saline here within the vessel. So that indicates the catheter is within the vessel wall. So coming to specific cannulations. So far we have seen that ultrasound technique improves successful cannulation rates, lowers the cannulation time, reduces the needle redirections, lowers the posterior wall perforations. So we have many sites for the central venous accesses, like into the subclavian vein, deep veins providing access to the SVCR, IJV, subclavian vein, and the axillary vein. Into the IVC are the common femoral vein. So every time the vein will be accompanied by an artery and a nerve in the neurovascular bundle. So here, this is the first image. A is the IJV. IJV is normally located in the anterior neck. In the upper neck, it is located lateral to the airway and anterior to the sternocleidomastoid. In the lower neck, it is located between the sternal and the clavicular heads of the sternocleidomastoid. That is also known as a Sedilot's triangle. So IJV will be accompanied by the common carotid artery and the vagus nerve. See, common carotid artery and the vagus nerve in the neurovascular bundle. So ideal position, vein will be located anterior and lateral to the common carotid artery. That is the ideal position where you can visualize and cannulate the vein. So some maneuvers, when using even ultrasound cannulation also, some maneuvers will enlarge the vein, and so that you can see the vein very easily and you can cannulate. So those maneuvers are, one is Trendelenburg, enlarges the vein, and the presence of mechanical ventilation also enlarges the vein, and Valsalva maneuver enlarges the vein. So these maneuvers enlarges the vein and helps in cannulation. And one more thing to note is head should be always in the relatively neutral position, because contralateral head rotation will make the IJV and the CCA, means internal jugular vein and common carotid artery overlapping. That will lead to inadvertent arterial puncture and hematoma formation. So that should be avoided. So head should be in the neutral position, Trendelenburg, mechanical ventilation, Valsalva to enlarge the vein, and know the anatomy of the IJV, and always know that IJV is accompanied by the common carotid artery in the neurovascular bundle, and avoid damage to the artery here. So next is the subclavian and the axillary vein. Subclavian vein is located in the infraclavicular region, and the axillary vein is located lateral to the outer border of the first rib. So two approaches are used for the subclavian vein, supraclavicular as well as the infraclavicular approach. Probe, always the problem with the subclavian technique is that the clavicle bone interrupts the optimal view of the vessel. So most of the time, the operators who are experienced in subclavian vein cannulation, they'll puncture the skin at the mid-clavicular point, so they do not miss the vein. Always in the subclavian vein cannulation, always long axis technique is preferred when cannulating. And as we have seen that in IJV cannulation, Trendelenburg enlarges the vein, but in subclavian vein cannulation, so Trendelenburg position does not enlarge the vein because of the surrounding structures. Because it is a fixed structure, surrounding structures, it will not enlarge. So, and always for the subclavian vein insertion, make sure that you have to evaluate the lung slide before and after the cannulation to quickly rule out the pneumothorax. And common femoral vein, it is located in the groin, femoral triangle below the inguinal ligament, medial to the common femoral artery and the femoral nerve. So common femoral vein is the junction of the superficial femoral vein, deep femoral vein, and the great saphenous vein. So here we can see the Mickey Mouse sign. Mickey Mouse sign is very important. That is seen during cannulation of the femoral vein in the short axis plane. where the common femoral vein is medial to common femoral artery and receiving the great saphenous vein. This is the Mickey Mouse sign. And CFV, a common femoral vein, is distended when hip is externally rotated and in reverse Trendelenburg position. And ultrasound guided femoral cannulations helpful in obese patients, those who are having weak pulse in shock, and those having anatomical alterations. So this image F, common femoral artery, superficial femoral artery, deep femoral artery combined to form the common femoral artery, and common femoral vein receives the great saphenous vein. So these are the anatomical structures that we commonly see during ultrasound cannulation of the IJV, subclavian vein, axillary vein, and the common femoral artery, and most importantly, the Mickey Mouse sign. So coming to arterial cannulations, radial artery and the common femoral artery are the commonly used arteries that are used for the arterial cannulations. Radial artery you can see here. It emerges from the bifurcation of the brachial artery at the elbow crease. So it is found in the lateral side of the distal forearm near the wrist, where it becomes more superficial and easier to palpate. This vessel is accompanied by the paired radial veins. See, here your probe is in the wrist on the radial side. So we can see the radial artery here that is accompanied by the paired radial veins. So also radial artery can also be seen and cannulated using ultrasound ultrasound in the dorsal segment found in the anatomical snuff box. In the snuff box also you can see and cannulate the radial artery. The permeability of the palmar arch must be assessed prior to cannulating the radial artery. So how do you assess the permeability of the palmar arch? Using the modified Allen's test. So the other one is using ultrasound and modified Allen's test. We have the modified duplex Allen's test, where we place the transducer in the anatomical snuff box. So first we identify the radial artery flow by the Doppler. So after identifying the radial artery flow, apply pressure proximal to the artery, site of proximal to the artery. Then we have to see the reversal of the flow. As you can see here, reversal of the flow indicates that there is patent flow within the palmar arch. If there is no reversal of the flow, there is inadequate palmar arch and you cannot cannulate the radial artery. So in the radial, near the wrist, on the radial side, you can see the radial artery accompanied by the radial veins. In the anatomical snuff box also, you can see the presence of the radial artery. The patency of the palmar arch should be assessed before cannulating the radial artery. That is assessed by the modified duplex Allen's test. Modified duplex Allen's test. So next coming to the femoral artery. Femoral artery, common femoral artery located in the femoral triangle, lateral to the common femoral vein and medial to the femoral nerve in the neurovascular bundle. So 20% of the patients have the common femoral artery bifurcation above the inferior border of the femoral head. So whenever we have to see the optimal position of the common femoral artery, see this is the common femoral artery and this is the femoral nerve. As we go down into the thigh, then we can see the division of the common femoral artery into saphenofemoral artery and the profunda femoral artery. So when we grow proximally, then we can see the common femoral artery and the femoral vein. So too high puncture causes retroperitoneal hemorrhage and too low puncture causes pseudoaneurysm formation and causes damage to the superficial and the deep femoral arteries and causes significant hemorrhage. And posterior femoral artery puncture also causes AV fistula formation. So we have to be very careful, identify the ultrasound anatomy of the common femoral artery before cannulating the femoral artery. So in a recent meta-analysis, they have shown that ultrasound-guided femoral arterial cannulation performed reduced the overall complication rate by 44% and reduced improvement in the first pass success rate by 42%. So we have seen the arterial cannulation of the radial artery, femoral artery, and the vein, IJV, subclavian axillary vein, and the common femoral vein. So that is the thing. So training and ultrasound guided vascular cannulation is very important to improve the rate of successful cannulations and optimize the patient safety. So there is no structured guidelines for this, but an expert consensus recommends at least 10 fully supervised ultrasound guided vascular cannulations to demonstrate competence to independently perform this technique. So finally, I want to conclude the class by saying ultrasound guided vascular cannulation should be considered the tool of first choice to provide access to central venous and arterial vessels, as well as some difficult peripheral venous cannulations in most critically ill patients. Ultrasound guided vascular cannulation demonstrated an improved global success cannulation rate and reduced overall complications. Ultrasound is used before the technique, during the technique, and after the technique. So before the cannulation to identify the anatomy and best target vessel, during the cannulation with real-time technique in short, long, and oblique approaches, and after the cannulation to demonstrate the optimal catheter position as well as to rule out the complications like pneumothorax. So, and optimal training is mandatory through formal programs and hands-on sessions. That's all. Thank you.